Good morning. It is 6:30 and in the series of excellent lectures going on by our residents from all over India. I think it is again in history that all our residents are taking extraordinary and the best of their lectures in this series. And in this series, today's lecture is by Pratyasa. Pratyasa is our third year MD Palliative Medicine junior resident. And Pratyasha is whenever I have seen her, she is very sincere, and whatever she is doing to the maximum perfection. So probably this lecture will also endorse whatever I am saying, and it will be moderated by Dr. Brajesh. Dr. Brajesh is our assistant professor faculty of our department. Again, very sincere, and Brajesh has contributed a lot in the departmental initiative, various initiatives which we have taken, like pain policy, end of life care policy, making opioid availability streamlined at new cancer center, that is National Cancer Institute, Jhajjar. So a lot of initiatives and a lot of contribution Dr. Brajesh has done for the department, and it is not that whatever I'm mentioning he has done, but his contribution are constant. So whatever, if new things he want to do, we just if ask Brajesh, then Brajesh will do to its maximum possible the best way. So this is the type of faculty we have in our department. So I will request Pratyasha and Brajesh to take over and say what they have brought with the topic respiratory drugs in palliative care. This is again a very important topic. We keep on struggling when a patient is breathless or when patient is having respiratory symptoms. Many a times we are really confused that which drug to be used and how we should use. So I think Pratyasha and Brajesh will explain that what are the various respiratory drugs we should definitely be knowing when we want to understand and when we want to learn palliative care. Okay, Pratyasha, go ahead.
Pratyasha, your mic is muted.
Sorry, sir. Thank you.
Yes, go ahead. Slide share karo. Shabash. Yeah, go ahead.
Thank you, ma'am, for the introduction. Thank you, sir, for moderating the seminar. I'll be beginning with the respiratory drugs used in palliative care. The contents will be as a clinical case, then the learning objectives, the common respiratory symptoms that we encounter, the commonly encountered respiratory drugs, a symptom-related approach, the case discussion, and various recent updates, and a summary. This is a clinical case which I encountered in my recent posting in the Pulmonary Medicine Department of AIIMS, New Delhi. He's a 32-year-old young male construction worker, a smoker with smoking index less than 400, with no comorbidities and no past history of tuberculosis or COVID-19, presented to the ER with complaints of shortness of breath that worsened from MMRC grade 1 to 4 over a period of 3 months. Dry cough for over last 3 months, associated with right-sided chest pain, low backache of NRS 8 on 10 for last 10 days. Now these will be our learning objectives for the session: to go through various drugs being used in respiratory palliative care, to understand the mechanism of action of various drugs, to understand the use and toxicities of the drugs, and some recent evidences. These are the various common respiratory symptoms that we encounter in our patients, like cough, dyspnea, bronchorrhea, hemoptysis, fatigue, and chest pain. Cough is basically a protective reflex, and there could be problem if there is decreased cough as well as increased cough. In cases of decreased effective cough, there could be retained airway secretions leading to infection. There could be aspiration followed by infection and the sequelae. There could be atelectasis. There could be respiratory compromise. And in cases of increased cough, it could be exhausting for the patient. It could be a social embarrassment. There could be complications like vomiting, syncope, rib fracture, hernias, and urinary incontinence. Well, the mechanism of cough, considering cough is taken by the afferents, basically when there's a stimuli like some irritation, these are the rapidly adapting receptors and the C fibers, which are the nerve endings which get stimulated. The afferent nerve endings are usually present in the pharynx, larynx, airways up to the terminal bronchioles, as well as the lung parenchyma. So they're carried by the auricular branch of vagus in external auditory meatus, as well as the superior laryngeal nerve. They are taken up to the nucleus tractus solitarius, that is the cuff center, plus there would be inputs from the cortical centers of cuff, which lead to the efferent as involuntary muscle actions, adduction of the vocal cords with transient closure of the upper airway, which leads to a contraction of the expiratory muscles with increase in the intrathoracic pressures, and there would be a rapid expiratory flow generated, which will result in cough. Well, this is the flow diagram of the thing that I just explained now. The thing that we have to mark in this is the centrally acting and the peripherally acting drugs that we will further discuss. This is the summary of the drugs for cough we usually use. The first being the pharyngeal demulcents, then the expectorants, the mucolytics, mucokinetics, mucoregulators, mucoactive antibiotics, antitussive agents, some adjuvant antitussives. These are the pharyngeal demulcents. Basically, these are agents which form a soothing film over the mucous membrane and hence prevent the stimulation of the afferent nerve endings, which we just discussed. So they prevent the conduction from the inflamed or irritated mucosa by forming a coating over them. And they only provide symptomatic relief in cough arising from the throat. And the agents used are methylcellulose and glycerin, which are basically soothing agents. Going to the mucoactive agents used for cough. Mucoactive agents are basically agents that have the capability of modifying mucus production, mucus secretion, nature of the mucus and its composition, and its interaction with the mucociliary epithelium. So these are the various mucoactive agents. Going to expectorants. Basically, expectorants are drugs that reduce the viscosity of the secretions, help in liquefying the viscid secretion that is available, and hence they relieve congestion and they facilitate the removal of those secretions by coughing them out. Guaifenesin is currently the only US FDA approved drug. Earlier, potassium iodide and sodium iodide were also used. Because of the undesirable effects, they're not being used currently. Going to mucolytics, they manage the mucus hypersecretion and their sequelae. So they have been rampantly used in conditions like COPD, cystic fibrosis, and bronchiectasis. So they depolymerize the mucin glycoprotein oligomers by hydrolyzing the disulfide bonds that link the mucin monomers. Hence, again, they help in simplification of the mucus. So examples are bromhexine and acetylcysteine that have been in use commonly. Bromhexine is a potent mucolytic as well as a mucokinetic. It induces thin, copious bronchial secretion, depolymerizes the mucopolysaccharides with the lysosomal enzymes. The dosage that we use is 8 mg TDS in adults as capsule, or in syrup it is available as 4 mg per 5 ml, which can be given as 10 ml TDS. Going to acetylcysteine, again, as I discussed, it opens up the disulfide bonds in the mucoproteins which are present in the sputum, makes the sputum less viscid, and it has to be administered directly into the respiratory tract, unlike bromhexine, as I discussed. So the formulation that it is available in is Mucomix. It is available as 20 mg per ml concentration. It is available as ampules in 1, 2, and 5 ml ampules. It can be nebulized and it can be also instilled through the tracheostomy tube. So mucokinetic agents. Basically, the mucokinetic agents are agents that help in the facilitation of the removal of the mucus. Ambroxol is a prototype of this class. It is a metabolite of bromhexine only, which we discussed is both. It is both a mucolytic as well as a mucokinetic. So effective mucokinetic and secretagogue properties help in the clearance of the mucus and facilitate the expectoration and ease productive cough. So as till now I have discussed, these all induce cough. So as in the second slide, I discussed that decreased effective cough, these agents should not be given in patients who have decreased effective cough, which can lead to retention of the secretions. The dosage forms that it is available is 30 milligram tablets or 7.5 milligram per ml drops or 30 milligram per 5 ml liquids, that is syrup. And the dosage that we're supposed to give is 15 to 30 milligram TDS. Moving on to mucoactive antibiotics, there are certain antibiotics that beyond their antibiotic property also have mucoactive property, like the help in the inhibition of the pro-inflammatory cytokines, as we know the action of the antibiotics. So particularly the macrolides, beyond their antibiotic effect, using the anti-inflammatory cytokines, they help in reduction of the mucus secretion. Erythromycin has been used in pan-bronchiolitis, which is a disease with increased secretions, and moxifloxacin has been seen to be beneficial in frequent exacerbations of COPD patients. These are certain evidences that I have found. The study mentioning pulsed moxifloxacin for the prevention of exacerbations of COPD. So it had seen that long-term therapy with moxifloxacin also was helpful in patients with COPD who had frequent exacerbations. This is another evidence for the macrolide treatment, which again prevented the acute exacerbations in patients of COPD. Going to mucoregulators, the last class of mucoactive agent. The drugs, they help in regulating the mucus secretion, that is, they decrease the secretion. So basically 3 categories are common: carbocystine, anticholinergic agents which block the parasympathetic nerve activity and hence reduce the mucus secretion. Glucocorticoids, as we all know, they are anti-inflammatory agents and hence they also help in the clearance of the mucus and they decrease the secretion as well. This is carbocystine. This has been quite often been used in patients of COPD and it is administered orally. With 250 and 750 milligram, 250 milligram to 750 milligram TDS. It is available in combination with antibiotics as well, which for which it is being treated for bronchitis, bronchiectasis, and sinusitis. Now, summarizing and going to antitussives that we had discussed as the 4th class of drugs for cough. Basically, antitussives are agents that control rather than eliminate cough. So we should use them in restricted conditions only. When we know the cause of the cough, we should treat the underlying cause only. But when should we use the antitussives is basically when there are dry, non-productive cough. When the cough is unduly tiring, it impairs the sleep or daily activities. The patient has other comorbidities like hernia, piles. The patient is planned for some ocular surgery. Patient has cardiac disease. Well, the antitussives are again centrally acting and peripherally acting. The centrally acting agents, as I'd seen shown in a previous slide, they help in reducing the threshold for cough at the central level, while the peripherally acting antitussive agents, they prevent the conduction of the tussle impulses. So opioids as antitussives, they are the most effective antitussives we have known, but they're limited. They're in limited use because of the inherent undesirable side effects. Mu opioid receptors are located both centrally as well as in the peripheral nervous system. Inhaled opioid antitussives, they exert their effect usually by inhibiting the excitatory non-adrenergic, non-cholinergic nerves via blockade of the mu opioid receptors in the airway. In addition to the effect on the sensory fibers, they also appear to inhibit airway cholinergic transmission. Now, codeine has been the prototype antitussive that has been in use. It is similar to in action, but it is less potent than morphine. It's very selective for the cough center and hence the use as the antitussive agent. The abuse liability, though low, is present. At higher doses, respiratory depression and drowsiness can occur, especially in children, and it is relatively contraindicated in asthmatics and with patients with diminished respiratory reserve. The dose used is 10 to 30 milligram, and for children, it is available as 2.5 to 5 milligram, and the syrup form is usually given as 8 ml TDS, which is available as codeine phosphate. Going to beta agonists. They are the frontline management options and treatment options for bronchial asthma and COPD, as we all know. The inhalation of the drug localizes the drug to the lung tissue, hence concentrating the therapeutic effect on the airway smooth muscles while minimizing the systemic distribution. So this has been seen that there is no correlation between the therapeutic effect of the inhaled beta-2 agonist and the peak plasma levels. Saying that most of the drug is like metabolized in the lungs itself. Classification of the beta agonists, they can be classified as ultra long acting, short acting, and ultra short acting. The ultra long acting drugs are armotrol, carmotrol. The long acting drugs are olodaterol, vilanterol, formoterol. Short acting drugs are salbutamol, terbutaline, levalbuterol, piributerol. The ultra short acting drugs are landiolol and esmolol. Well, the short-acting beta-2 agonists, they're the first-line medications for acute treatment in asthma symptoms and the exacerbations. They basically work by relaxation of the smooth muscle airways, and hence they prevent bronchoconstriction. The hallmark drug is salbutamol, and it has a very low onset of action, low duration onset of action with less than 5 minutes, and the therapeutic effect is 3 to 6 hours. As I discussed, it's a short-acting beta-2 agonist. Going to toxicities of the SABA that we just discussed, due to vasodilatory effect of the peripheral vasculature, they can be cardiotoxic, which can lead to arrhythmias, cardiomyopathy, and ischemia. The hypokalemia is a very common side effect that we know, which we use as therapeutically. Then muscular tremors are common. Also, hyperglycemia can be seen as beta-2 agonists can promote glycogenolysis, but it's rare. Going to long-acting beta-2 agonists, salmeterol has been the most studied LABA. It is administered as DPI as 50 microgram per actuation as twice daily dosing. The other drugs are formoterol and vilanterol. Formoterol is the fastest acting inhaled LABA, and it is available for the treatment of asthma with action as rapid as that of salbutamol. Now, looking at the pharmacological properties, we can see that the time for the mean onset of action, we can see that all three drugs have very low onset of action only. It's like formoterol at 7.2 minute, which is comparable to that of salbutamol. Similarly, for salmeterol also, it is only 14 minutes. Similarly, for the time to maximum effect, it's only 2 hours in formoterol, 2 hours in salmeterol. Both of them are LABA, and for salbutamol, it is 30 minutes. And the direction of action, as we can see, it is 12 hours for both the long-acting beta agonists and 4 to 6 hours only for the short-acting one. Going to inhaled corticosteroids, they're the first-line anti-inflammatory therapy for persistent asthma of all severities. They basically reduce the airway inflammation and consequently influence the hyperresponsiveness, which is very common in patients of bronchial asthma. So these are the various drugs that are being used. The mechanism of action, as we can see, corticosteroid acts at the glucocorticoid receptor and ultimately leads to genetic regulation, the gene regulation, which helps in decreasing the pro-inflammatory cytokines and helps in increasing the anti-inflammatory cytokines, hence mediating decrease in the inflammation. Looking at the pharmacological properties, basically all of them have a similar onset of action, and the half-life also, as we can see, for fluticasone, it is the highest, and followed by mometasone. The rest, beclomethasone and budesonide and cyclosamide, are like half-life is it is short-lived only, 0.5 hours, 2 hours, and 3 hours only. Going to the metabolism of the inhaled corticosteroids, the drug that is inhaled, 10 to 60% is deposited in the lung itself, and it can be seen that 40 to 90% can be swallowed and absorbed through the gut, leading to the first pass metabolism in the liver and leading to systemic absorption. Similarly, from the lung, with the macrophage clearance, it can lead to systemic absorption, which can lead to some systemic side effects. These are the adverse effects. The local effects that are seen are oropharyngeal candidiasis, and patients should always be advised to wash their mouth after using the inhaled corticosteroids. Dyspnea can be seen, reflex cough can be seen, bronchospasm can be seen. There could be damage to bronchial mucosa because, as I discussed, it works by doing the gene regulation, hence can induce dysplasia. Again, it is absorbed from the lung, but it can be 50% of the inhaled drug can be swallowed, so causing some degree of systemic bioavailability and leading to systemic side effects. So these are the various systemic side effects that are seen, but again, they are not that significant enough for stopping the inhaled corticosteroids, as they are the first line agents for all severities of asthma, as I discussed. This is a publication which had taken salmeterol and fluticasone uh, into account for survival in patients of COPD. So basically, toward a revolution in COPD health, the TORCH, it was the largest trial of salmeterol, and it showed that salmeterol significantly decreased exacerbation rates. It improved lung function and improved the health-related quality of life. Although not designed to evaluate survival, the study did not find increase in mortality with salmeterol, so supporting its safety. Going to ipratropium bromide, another common drug used. This is a short-acting muscarinic antagonist. Basically, it works on the M3 receptor. The parasympathetic nervous system, as we know, plays a major role in regulating the bronchomotor tone. It helps in opening up the medium to large airways. It is one of the WHO's essential drug list drugs. It has minimum side effects in inhaled doses, and it has to be nebulized 2 to 4 times a day. As I discussed, it's a short-acting muscarinic antagonist. Going to tiotropium. This is a long-acting muscarinic antagonist. It is a potent, long-acting, selective anticholinergic bronchodilator. It has M1, M3 receptor selectivity, and it is again convenient dosing schedule it has, which is OD dosing, which helps in better patient compliance. The dosage used is 2.5 microgram per actuation with 2 actuations OD. So this International Journal of COPD, in the article effect of tiotropium on the health-related quality of life, had seen that in patients of COPD, it decreased dyspnea, it reduced hyperinflation, improved the overnight arterial saturation, it led to fewer acute exacerbation and improved the quality of life. This is a study comparing tiotropium and ipratropium for patients in COPD. In a systemic review that compared this, tiotropium was associated with improved lung function, fewer hospitalizations, and fewer exacerbations. Now, this is another category of combination available, that is the combination of the long-acting muscarinic antagonist and the long-acting beta-2 agonist. So when they're given together, they increase each other's efficacy. As we can, like 3 mechanisms basically. The LAMA, that is the long-acting muscarinic antagonist, they predominantly act on the proximal large airways, while the sympathomimetics act on the distal small airways. Hence, when given together, they potentiate each other's action. Then the bronchodilation also occurs by different mechanisms, as I have discussed earlier. In beta agonists, they directly act on the smooth muscles, and prevent the bronchoconstriction, while the muscarinic antagonists also cause bronchodilation by reducing the cholinergic tone. The LABA has rapid onset of action, as we had discussed, while the LAMA has sustained activity. Hence, the co-administration can be effective for intermediate time. These are the various LAMA-LABA combinations that have been approved. Glycopyrronium indacatrol, tiotropium olodatrol, aclidinium, formoterol, umeclidinium, and bilanterol. Going to dyspnea, another significant complaint seen in patients of our palliative care. Dyspnea, as we all know, has been defined by the American Thoracic Society as a subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. The word that we're supposed to mark here is subjective. Basically, the prevalence of dyspnea is 9 to 13%, and in patients greater than 70%, it's as significant as 37%. 50% of inpatients and 25% of the ambulatory patients present to the ER with dyspnea, and counting to the number, 3 to 4 million per year visits in ER is because of dyspnea. Going to the mechanism of dyspnea, the afferent signals can be conducted by 3 receptors, by 3 pathways. The chemoreceptors, which sense the change in carbon dioxide, the mechanoreceptors, which change the sense the change in stretch receptors. Then there are the metaboreceptors, which sense the change of the vascular pressure. So chemoreceptors can be peripheral and central. The mechanoreceptors are present throughout the airways and the chest wall. They are the stretch receptors, irritant receptors, and the J receptors. The metaboreceptors are basically pulmonary vascular receptors, and they sense change in pulmonary artery pressures. This is a diagram summarizing the afferents for dyspnea as I discussed. Now going to chronic dyspnea. This is the frequent complaints in our patients. So chronic dyspnea can have various causes. Going to the respiratory causes of chronic dyspnea, basically in diseases of the airways like asthma and COPD, diseases of parenchyma, that is ILD causing fibrosis or hypersensitivity pneumonitis, chest wall disorders like kyphoscoliosis, neuromuscular weakness in ALS, or pulmonary vasculature disorder causing pulmonary hypertension. In this, as I discussed, the metaboreceptors get sensed. Going to cardiac causes of dyspnea, the most common being left heart failure, then cardiomyopathy, coronary artery disease, diseases of the pericardium, restrictive pericarditis, cardiac tamponade. And there are some miscellaneous causes: anemia, deconditioning. Deconditioning is a psychiatric condition, and psychological causes like anxiety. Going to medical management of dyspnea. This is the etiological approach basically, when we have to find the cause and treat. So when there's infection, we should give the patient appropriate antibiotics. When the bronchoconstriction is reversible, we should go for bronchodilators. If the cause is due to pleural effusion, we should go for drainage and consider pleurodesis if possible. If the cause is anemia, we should go for transfusion. If the cause is heart failure, we should adequately give the patient diuretics and AC inhibitors. If the cause is lymphangitis carcinomatosis, we can give dexamethasone trial. If it's SVCO, we can go for dexamethasone, radiotherapy, and stenting. Drugs for symptomatic management of dyspnea. So as I discussed, this was for medical management of dyspnea, but this is only for symptomatic management of dyspnea. So 3 classes of drugs basically: opioids, the benzodiazepines, and oxygen. Opioids, as we all know, it reduces the sensation of breathlessness, and the dosage that we prefer is, we start with tablet morphine 2.5 milligram SOS followed by QID. The benzodiazepines, again, they help in reduction of the symptoms by helping in managing the fear and anxiety that is associated with dyspnea. The dosage can be tablet lorazepam 500 mics to 2.5 milligram OD, tablet diazepam 5 to 10 milligram OD. Sublingual lorazepam can be given 0.5 milligram to 1 milligram SOS in cases the patient has panic attacks. And oxygen, it is useful only in patients, only in selected group of patients, and there has been no correlation with the intensity of dyspnea and administration of oxygen. So this from the Oxford textbook of palliative medicine. Pharmacological treatment of dyspnea, it has been seen that clear evidence is for oxygen and opioids. Some evidence has been seen for the anxiolytics, nebulized the furosemide and heliox, and limited evidence is there for the antidepressants, phenothiazines, indomethacin, and inhaled topical anesthetics. Going to oxygen therapy, well, hypoxia can lead to a sense of air hunger on stimulation of the peripheral chemoreceptors. And oxygen therapy has been in wide use in patients with acute hypoxemic conditions, as we all know. But long-term use in chronic hypoxemia has been also well supported by studies. And in palliative care, it is only used for symptom relief. Even when the criteria for LTOT is not met for symptom relief, it can be given. Opioids for breathlessness. There have been various studies considering opioids in various groups. In the patients of cancer, there was no significant difference in dyspnea once the patient was already on morphine. So as we discussed, low dose morphine has been effective in patients of cancer, and if the patient is already on treatment of morphine and we increase the dose, it has not been seen to have significant relief. In patients of COPD, there has been significant improvement in dyspnea scores and sleep. And in patients of heart failure, again, the evidences are dicey. That is, the severity reduced from the baseline, but there was no statistically different evidence seen between the drugs used, that is morphine, oxycodone, or placebo, as per the Oxbury et al. Study. So this needs further evidence. These are some evidence that have been there for morphine for refractory breathlessness. This study basically saw the effect of sustained release morphine for refractory breathlessness in COPD patients. So it saw that for moderate to very severe chronic dyspnea due to COPD, disease-specific health status improved after administering regular low-dose oral sustained release morphine. The respiratory rate decreased without a change in the PSO2 or PO2, indicating no clinically relevant differences in the alveolar ventilation. Hence, saying that it can be safely given in patients of moderate to even very severe patients of chronic dyspnea due to COPD. This is another study which has been done for nebulized morphine in patients of COPD. It showed an apparent reduction of the chronic breathlessness intensity accompanying severe COPD with morphine delivered by the dosimetric nebulization system, which ensured that the delivery of the drug was to the desired level to the airways, and it could prevent the systemic absorption. This is another study. It saw the inhaled fentanyl improved exercise endurance during the high intensity constant work rate cycle exercise in COPD patients. So again, it was associated with significant and potentially clinically important improvements in the exercise endurance. In the patients used were mild to severe COPD. Nebulized opioids for the palliation of dyspnea and terminally ill patients. In this study, they used the drugs morphine, fentanyl, and hydromorphone, and the nebulized opioids may provide subjective relief of dyspnea and terminally ill patients in mild to moderate adverse effects. So the conclusion. Going to refractory dyspnea, as we discussed, these are the few drugs and class of management that we can do for refractory dyspnea. Oxygen can be given for hypoxemic patients as well as for non-hypoxemic patients, as I said, for symptom relief. Similarly, for the pharmacological approach, it could be the opioids, the psychotropic drugs, inhaled furosemide heliox, and the non-pharmacological approach can be done by adequate rehab. Going to another significant symptom that we see in our patients, that is bronchorrhea. Bronchorrhea is basically defined as more than 100 ml excess sputum production per day. We see many patients with malignant respiratory tract tumors, which leads to massive fluid production, which is very distressing for the patient. It can lead to worsening dyspnea and can be associated with cough. Earlier, it was associated with bronchoalveolar carcinoma specifically, but the term bronchoalveolar carcinoma has now been abolished. So currently it is specifically associated with the mucinous adenocarcinoma patients, and it has been seen in pulmonary metastasis patients as well. Going to management of respiratory secretion, this is a study that I found, pharmacological management of bronchorrhea and malignant disease. It is a systemic literature review. There have not been much studies considering the pharmacology for respiratory secretion. So in this systemic review, they included the studies which with drugs, that is the corticosteroids, macrolide antibiotics, inhaled indomethacin, octreotide, and the tyrosine kinase inhibitors, which are frequently used in patients of CA lung. So the study found that there was significant reduction in bronchorrhea in inhaled fluticasone, that is the inhaled corticosteroid, erythromycin, which is a macrolide, octreotide, geftinib, and the erlotinib. Geftinib and erlotinib are the tyrosine kinase inhibitors. Going to another distressing symptom of the end of life, that is the respiratory secretion at the end of life. Glycopyrronium is the preferred drug as it has no central side effects and it is equally potent and efficacious. So the dosage that is preferred is 0.2 to 0.4 milligrams subcutaneous SOS. But if the patient has really distressing symptoms and it is end of life only, it can be given as continuous subcutaneous injection in the dosage of 1.2 milligram to 2.4 milligram over 24 hours. The other medications that are used as hyoscine, it is available in two formulations, the butyl bromide salt and the hydrobromide salt. So this is the various dosage, that is 20 milligram subcutaneous SOS for the hyoscine butyl bromide preparation, and for the continuous infusion can be given as 40 to 120 milligram over 24 hours. Similarly, for the hydrobromide formulation, 0.4 milligram subcutaneous SOS and 1.2 to 2.4 milligram over 24 hours. So the this hydrobromide formulation has similar dosage as that of the glycopyrronium. Going to COPD. COPD is an increasingly significant source of morbidity and mortality worldwide. It has been the fourth leading cause of death worldwide, and despite underdiagnosis in early stages, the British Lung Foundation has referred these patients as the hidden millions. Drugs for COPD that many of the drugs that we have already discussed, these are the inhaled medications that are used for COPD. The muscarinic antagonist, the SAMA and LAMA, that is the short-acting muscarinic antagonist, ipratropium. The long-acting muscarinic antagonist, that is tiotropium, umeclidinium, and aclidinium. The beta-adrenergic, that is the beta-2 agonists, SABA and LABA, that is short-acting beta-2 agonist, salbutamol and terbutaline. Long-acting beta-2 agonist, salmeterol and formoterol. The corticosteroids, fluticasone, budesonide. Going to the systemic medications that are given in patients of COPD. The xanthine class of drugs, that is the theophylline, aminophylline, doxyphylline. The phosphodiesterase 4 inhibitors, that is roflumilast. The antibiotics, which should be chosen as per the regional antibiogram, or as we discussed, the anti-inflammatory macrolides can be given. And the IgE monoclonal antibody, omalizumab. Going to the study, COPD, a palliative medicine review of the disease, its therapies and drug interactions. In COPD, many of the advanced therapies align well with a comfort-oriented approach and hence help in improving the health-related quality of life, reducing the symptom burden. Palliative care for patients with COPD, as with other patients receiving palliative care, require a continued balance of the life-prolonging as well as the health-related quality of life care strategies. This was the conclusion of this article published in the Journal of Pain and Symptom Management. This table has been taken from the same journal. So the COPD therapies that were reviewed, it was seen that there was significant reduction in symptom burden in all classes of drugs except phosphodiesterase 4 inhibitors. And the improved functional exercise capacity was again seen in almost all classes of drugs except few mucoactive agents. And it was a bit dicey with the theophylline drugs, and it was not seen with the phosphodiesterase 4 inhibitors, that is roflumilast. And again, similar for the improvement in the health-related quality of life. This is another study which mentions the commonly prescribed medications among patients in hospice care for COPD. As we all know, like other advanced diseases, the end-of-life COPD care is more focused on palliative therapy and acute symptom management, as evident from the lower prescribing rates of the maintenance medications compared to that of the therapies for acute exacerbations. So there comes a time when the primary physicians they decide that the maintenance medications can be tapered off and symptomatic relief can be given by the therapies for the acute exacerbations. Although it may be practical for the healthcare providers to adhere to recommendation guidelines for patients in stable COPD, the recommendations have to be more flexible in the end stage disease. Thus, individualization of therapy is more essential. This is a table taken from the same article. As we can see, the opioids have been the most frequently prescribed drugs, followed by oxygen therapy in the hospice patients. Now, coming back to the clinical case that I had discussed, repeating again, he was a 32-year-old young male construction worker, smoker with a smoking index less than 400, with no comorbidities and no past history of tuberculosis or COVID-19. He presented to the ER with the above complaints. Going to case discussion, the patient was evaluated and the CCT chest showed bilateral lower lobe consolidation and cavitary changes in the right upper lobe of lung, along with multiple lytic lesions in the multiple vertebral bodies. The patient was transferred to the pulmonary medicine ward and was further evaluated. He was suspected to be a case of disseminated tuberculosis with pod spine. However, CT-guided biopsy done from a vertebral lesion in the level of D7 revealed it to be a case of non-small cell lung carcinoma, adenocarcinoma type with EGFR positivity. He was started on first-line chemotherapy with carboplatin and pemetrexed at 50% dose because of ECOG PS3, which was stopped in view of disease progression and poor response to the therapy. His shortness of breath was exacerbated and he was started on NIV in view of type 2 respiratory failure. Palliative medicine consultation was sought for symptom management and patient was started with NSAIDs in view of bone pain and low dose morphine was started in view of dyspnea. Gradually, his pain medications were escalated and his pain was controlled. Palliative radiotherapy was given to the osteolytic lesions and injection zoledronic acid was given. The shortness of breath gradually improved with an optimum dose of morphine and oxygen therapy. So gradually the patient was tapered off NIV and he was doing good with minimal oxygen support via the nasal prongs, and his NRS had become 1/10 and he was planned for discharge with the targeted with the prescription of the targeted therapy, that is osimertinib, which is a tyrosine kinase inhibitor, third generation tyrosine kinase inhibitor. So in this we can see there was a holistic management of the patient. These are the various recent advances that I have found. Octreotide as a novel agent for management of bronchorrhea in mechanically ventilated patients. So in this study, they concluded that it was clinically significant decrease in bronchial secretion rate when octreotide drip was used. And octreotide is a safe and easily available agent, so its effectiveness in ICU patients with excessive bronchial secretion should be further investigated in RCTs. And again, octreotide can be tried and investigated in patients who are not mechanically ventilated. So this is another 2022 study which showed the efficacy of magnesium sulfate in patients of COPD. It was a systematic review and meta-analysis. It saw that IV magnesium sulfate used in patients of COPD was associated with a favorable deviation in the FEV1 it was able to reduce the exacerbation when used alone, and as well as when it was used in cases in help with salbutamol. So there was more significant increase of efficacy when it was used in adjunct with salbutamol. It was associated with significantly fewer hospital admissions from the emergency department. So the take-home message that I want, a sensation of breathlessness is the most troublesome symptom that we have experienced in around 90% of terminally ill patients. Traditionally, palliative care has been associated with cancer population. However, it's time that patients with advanced cardiorespiratory disease experience similar symptom burden and a lower quality of life be also addressed with palliative care. Distressing symptoms like the refractory cough, bronchorrhea should be addressed with importance in the end of life, and a multidisciplinary approach with holistic assessment should be implemented for all advanced diseases. Thank you so much.
Excellent, Pratyasha. Beautiful presentation, and the way you have given the example of our own pulmonary emergency department patient and the way palliative medicine has contributed. I remember this patient, and they are very, very grateful that they were not knowing that this patient, COPD patient, can turn out to be like this, and they can improve quality of life this. So I think this is a good example of integration, intense integration of palliative medicine in various other disciplines. Now, Brajesh, what I will do, what I want that there are a lot of questions from Dr. Rajshri, Dr. Nandini, and from others. So please go for the question one by one, and then we will take comments from all. So what I will suggest, Pratyasha, you can stop sharing slides so that people can come on this. Okay, and Brajesh, go one by one with the question and answer. Okay.
Yes, ma'am. Thank you, ma'am, for your kind words. There is one question from Rajshri. Centrally acting antitussive increase the threshold for cough. Yes, all centrally acting antitussives are basically increases the threshold for cough. So their cough reflexes has been decreased. And now, could you explain the mechanism of action of esmolol, which is a beta blocker in the management of bronchospasm? Actually, there is a typing error. Actually, that the drugs under class of ultra short acting beta agonists, basically the both drugs are beta blockers. That is by mistake. Is hyoscine hydrobromide formulation available in India? Actually, we have to search for this. I haven't know about the availability of hyoscine hydrobromide, but yes, this butyl bromide is freely easily available in our centers. What are the oral medications which can be given for bronchorrhea patient on OPD basis? For bronchorrhea, we can give steroids. Even we can try erythromycin and also tyrosine kinase inhibitors. Jeftinib is also given in oral. Is there recent study on using opioids for severe pain, high dose? Actually, we are not. I think I'm not aware about any recent study, but we many times we encountered a patient with COPD with severe pain, and for their pain management, we titrate them like a normal patient, and we are not afraid about the COPD and the respiratory depression. Basically, till the pain settlement or the patient become pain free, the respiratory depression does not occur. So in our setup, we have encountered many patients with COPD with severe pain, and we are not afraid of giving morphine in higher dose to that patients.
So all the questions are over, Brajesh?
Yes, ma'am.
Okay, so there is last one more question is that is morphine nebulization formulation available in India? They want to learn that nebulized morphine. I don't think there is a separate formulation available in India right now. Okay.
Yes, ma'am. Even, ma'am, I searched the literature regarding the morphine nebulization and different studies. All studies that mentioned by Pratyasa are very few studies, like they have done in 10 patients or 15 patients. There is one study published in 2017. They reviewed the literature, and they also found around 10 to 15 articles for opioids nebulization, and they also concluded that a large trial is recommended for establishing about morphine nebulization for dyspnea.
So thank you, Brajesh. I think this lecture has given a lot of information, new information. So what Dr. Rajni wants to say, just let me read. I would like to say that most antitussive expectorant combination available in market are not effective, and the ATS guidelines for chronic cough also do not recommend them. It adds to polypharmacy though. So what is your take on this? Maybe we can ask Dr. Nandini or Dr. Jennifer. They are here. So Dr. Nandini and Jennifer, would you like to comment on the Rajni's comment, please?
Yes, thank you for this excellent presentation. Chronic cough can be a problem. There are lots of, like Dr. Ranjini has written, there are lots of formulations, but some are, it is not universally effective. So often, finally, central antitussives, when it becomes refractory, are effective. There are some newer studies on use of other medications like gabapentin. I'm not sure, gabapentin for chronic cough, mirtazapine for refractory breathlessness. So these are small other things we can try when we are really stuck with refractory symptoms. But I agree with Dr. Ranjini's comment that there are so many cough formulations with different combinations, which are not effective. We could try and we should decide to stop if it is not continuing to be effective.
Jennifer, Nandini or Dr. Stanley, you want to say? Dr. Stanley, you want to say? Yeah, go ahead.
One useful thing for a dry hacking cough, a simple demulcent, is honey, and you can combine it with ginger and lime, so that's a good, effective, simple remedy. The other thing I would like to mention is about the so-called noisy breathing or due to secretions. It's important that whatever is already secreted is not going to be helped by all your glycopyrronium or hyacinth butyl bromide. It must be removed by positioning or gentle mopping. Otherwise, if you keep on increasing your anti-secretory drugs, it will cause a lot of dry mouth, which is very distressing. So that's the thing. And the other thing is, there is no need for this so-called continuous subcutaneous infusion because it's not possible in many places. So giving all these medicines, glycopyrronium or this thing, what do you call hyacinth butyl bromide, every 6 to 8 hours, subcut intermittently also is helpful. Thank you. Thank you for that.
Stanley, for very important comments. Very important comments. And I think since ages, our grannies are using ginger, honey, and all these for cough. And I think it's a high time that we should conduct some kind of a study on this and prove that these drugs, these substances are also very, very useful and significantly useful for cough. And rest of the comments, I agree that it's not that giving medication, but we should be very aware of the side effects. That it should not happen that all over the respiratory tract there is dryness and patient is more distressed. So we have 9 more minutes. So Nandini and anyone wants to have any comments on the overall lecture or something new if you want to say? Nandini?
Sushma ma'am, if I may just add a couple of points on
yes, please
this
go
is
ahead.
Purely a respiratory issue, so I thought I should chime in.
Please introduce and go. Dr. Rajni, you are speaking?
Yes, Sushma ma'am.
Yeah, please go ahead.
Yeah, I'm Dr. Rajni Surinder Bhatt, and I'm a pulmonologist. So clearly, this topic was of great interest. And firstly, I want to say, Dr. Pratyasa and Dr. Brajesh, this is a very comprehensive presentation. I would like to suggest only a couple of things. One, which is that when we talk about all the syrups that are available, patients come to us for chronic refractory cough with a laundry list of prescriptions, and most of them have at least 3-4 syrups combinations in them. Most of the syrups available in the market are combination ones, and really it's such an expense for the patient. And none of them really are effective. As Dr. Stanley said, what I use in my practice is really going to be stuff that's available at home. So demulcents and things, and just something to keep the mouth moist, to create that protective membrane for the pharyngeal mucosa is all one is trying to do. They don't find mention in any of the international guidelines for management of cough. So a very nice document is the ERS 2020 edition of the guidelines for management, diagnosis and treatment of chronic cough in children and adults. And it only answers 4 or 5 questions. So what it looks at is opioids, what it looks at is reflux cough, what it looks at is demulcents, and the gabapentin that Dr. Jennifer Jeba mentioned. So I would say the majority of cough is about treating what is the underlying cause. Dr. Shobha mentioned Lasix for cardiac cough. So it's about understanding where the cough is coming from rather than just, giving a whole lot of syrups. The first thing I do when patients come is cut out all of those things in their prescription. It might ease the financial burden a little bit, if anything at all. The second thing I would like to say is that with COPD and with asthma, where the cough and breathlessness, they usually go hand in hand. So again, it's important to make sure that we use the inhaled corticosteroids. Again, inhaled corticosteroids find greater mention in the cough guidelines than any of these expectorants do. So inhaled corticosteroids are also effective for cough. That's the other thing I'd like to mention. Also that I do think that's a little overquoting to say that more than 50% of, or up to 50% of the drug can be absorbed, because inhaled corticosteroids are the safest drug and do not have any of those cushingoid side effects. We have patients taking them for 30 years with none of those effects. I greatly appreciate your clarity in talking about opioids with dyspnea. That's one thing that we as pulmonologists need to get more familiar and start implementing more. And you know, that I think is a very, very important piece over here in what you've mentioned. So thank you.
Excellent, Dr. Rajni. What an excellent contribution of this lecture and summary. Thank you very much. Thank you.
Thank you, Sushma ma'am. There's one drug which unfortunately has now not been available in India. I want to add that again. It used to be called it's called Tessalon Pearls. It's benzonatate, and if it ever comes back for dry cough into the markets, that's a good one to use. At least a third of the patients respond to it really beautifully. So benzonatate is one thing which, if it comes back, it's available in other countries. Used to be available in India, not in.
So,
Excellent, Rajni. Dr. Rajni, excellent. Yes, please go ahead. Yeah.
one more thing, all the non-drug measures also must go hand in hand, you know, especially a calming presence. You as a physician who's helping the patient and family, the calming presence is very important, and how you can help the family also to be a calming presence is very important. And so those non-drug measures also must go hand in hand.
Excellent, Dr. Stanley. Pratyasha has in her slides given subjective feelings as a bold, and non-pharmacological therapy will work a lot in all these patients. So, are there any other comments? Otherwise, we can stop here. Anyone wants to say anything? Somebody has raised hand. Who has raised hand? I don't know. Anyways, so I can see there are no more comments. So thank you very much, Pratyasha. It was an excellent overview, and I hope everybody has learned a lot of things from your lecture. It is not learning basically, it is just an updating of all the medication. And Dr. Rajni has briefly summarized so well that what works and what doesn't work, because she is the one who is looking after all these patients every day. So, and you have given an excellent example how palliative medicine can help pulmonary medicine department, and how our pulmonary medicine department is using help of palliative medicine department to maximum in these days. So these are very good examples, and this can be learned and this can be practiced in all the institutions, so that we can have best quality of life of our patient. Thank you very much. We are finishing 2 minutes before, but we all have to go for work. So we'll see you next week, Monday before 6:30.